Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hello, and welcome back to the Sit and Stay podcast, the show where mental health providers learn to keep their practice healthy alongside their patients. We are brought to you by RipsyTech, an electronic health record company dedicated to addressing the mental health crisis in the United States. As always, you are joined by RipsyTech product manager Parker Anderson, that's me, and as always, we are joined by founder and CEO of RipsyTech, I don't have a word for it, but he's just a really awesome guy, Tom Tarshis.
Thanks for that, Parker. Yeah, before we always start the podcast, we sort of do a little prep, and sometimes you forget to prep that you have a adjective ready, but then maybe I suppose you still felt compelled to pull one off, but it worked well regardless.
Thanks, Tom. Always appreciated. So for this week's episode, we wanted to talk about maintaining a patient list. So as a provider, you have patients that you see, and I believe the idea of like maintaining that patient list is kind of being on top of like, hey, how frequently am I seeing these patients? When was the last time I saw this patient? Would I still consider them my patient? Those different types of questions. And so I think the first question to dive into that, and you might be able to kind of give your overarching thoughts on this, but, why is it important for providers to be actively maintaining awareness of their full patient list, and how can this prevent, unethical or unintentional like terminations with the patient where, hey, maybe you don't consider them their patient anymore, but they consider you to be their provider. How do you avoid that type of situation?
Yeah. And this is, something that is covered in training, but it's maybe sort of falls also into one of those sort of businessy topics that a lot of people maybe don't get to talk about or hear about. And, at the most basic level, being aware of who your active patients are, how they're doing with treatment, when did you see them last, is good care and an important care principle. So regardless of these other any other implications, it is important to know who your active patients are. That being said, Parker, right, people who are full-time or very busy, that number can easily get to 100 or more. And when you're busy after long days and have life and sleep deprived because of new babies, like, maintaining your patient list aggressively is something that almost always falls by the wayside. And even if you've got a bunch of, have some OCD principles, which can help make you a good business owner, often, checking in on what your patient list is like does fall to the wayside. And I think like this topic came up because I'm like, oh, let me go ahead and check how my active patients are. And that's what got an idea to do the podcast about this. But for, the couple other, again, I don't like using the fear principle to manage how we do things, but there are these stories, it's fairly statistically unlikely, but theoretically, you could have seen a patient a year ago, and then you stopped seeing them. But there was, whether or not there was communication with the patient, there's nothing written in the chart. And then something awful happens with the patient. They get harmed, they harm someone else, there's some type of lawsuit. And yeah, you might still be the mental health clinician on record for that patient. And when you're in that situation and you say, well, no, I haven't seen them in a year, but you haven't properly maintained yet your medical record and or documented for some other level that this is no longer your patient, it is something you can get in trouble for. And sometimes it's a more reasonable thing to get in trouble for, because we should make sure what's happening with our patients. And if we're not seeing them, we should close that. And then, so there's that legal implication. And then there's also just the good care, besides the ethics of knowing if your patients are active and doing the good care. And then there's also a sort of business piece that for planning your practice growth and income and things like that, you should be aware of, your active patient list at all times.
Is this why maybe a lot of providers would insist on doing like a closeout session if a patient is deciding like, hey, I would like to terminate treatment, like the provider might want to say, it would be good to do one last session to kind of close out our like relationship, so to speak?
Well, yeah. And that's, there's a lot of different situations in which your therapeutic relationship can end with a patient. And I think, we're going to talk about some of those. It is always, regardless of why the termination is happening, it is always great to sort of have it documented that, next time will be our last session, or this is our last session. We both agreed to end this relationship because of X, Y, or Z. And to have that, it's always good to have a conversation about end of care. Hopefully it's normally in the context of, hey, you're doing better. I don't think we need to keep you open actively, but you can always reach back out whenever, and we can always, bring you back in for care. But that's probably that's probably not as common as other terminations.
So let's say you can't reach your patient for an extended period of time. What should you be, from an ethical standpoint, what should you be considering before you would then kind of consider termination to be the appropriate step?
Yeah. So, and this goes back, and maybe in a very early episode, we talked about this, Parker, with, what is the standard of care for frequency of mental health appointments? And so, if you're in weekly therapy, it's very obvious to know how your patient's doing and then when to space them out and get down to once a month. If you're doing just medication services, I think that is where you can definitely lose track of some of your patients. And so, and there's sort of different standards of care for, is this a minor? Is this an adult? What type of medicine are they on? I think there are some places where you may see a provider for 15 minutes once every 6 months, such as some big entities like Kaiser, or places where they don't have enough services for a large number of population. I really don't think that's ethical or appropriate, especially not for someone in a smaller group or smaller practice. There is no hard, fast rule about this, but the general rule I follow is that for minors, really once every 2 months, you should be seeing that patient, even if things are going great and very stable. For adults, I do think there are cases where you could stretch it out to maybe once every 3 to 4 months, depending on, how stable they are, how long you've known them, and are they reliable on communication if something happens. But going any more than that, I think, is really pushing the boundaries of good care. So that's an important. But then, so if you do have some patients where you're seeing them once every 2 months or 3 months, those are the people that you could miss a couple of visits and then all of a sudden be like, oh wait, I haven't seen Joe in like 10 months. What is happening with him?
Right.
And that's, and I, just to be full disclosure, when I was recently looking at my patient roster, which in our software makes it very easy to do. So I have no excuse. I'm like, oh, what is going on with this patient? And I sort of quickly reached out to the family to get an update. And it was one of these situations where, you know, they had been, the medication dose was less than it had been. So their 90-day supply was actually could last sort of a whole year. And this is not on the family because, you know, a lot of people who are seeing you for medicine, they wait till their medicine is low and then they reach out. So I felt bad about not having an update in such a long time. Everything's okay, and this is a very responsible family and everything else. But and Parker, right? It does also sort of remind me we should just go ahead and build in. Right now, you can see your sort of patient list and when they were last seen, but we can one up the game and you know, put a little, hey,
like a little reminder notification.
Reminder. You have 2 patients that haven't been seen and you know, we can let people set the timeline, but it would have been helpful to get like a red warning, like, hey, you haven't seen this person in 4 months.
Yeah, that would be really easy to do, to add to that specific page. I think there's always room for improvement. I could go on and on and on about this topic of just different ideas of like, hey, what could we do with that page? But I guess to keep things on track, how about like a poor therapeutic fit? And I think that this can kind of go both ways, right? Like a patient might feel like there's a poor therapeutic fit and have a conversation with you. You might feel like there's a poor therapeutic fit. I guess since right now, you know, our audience is primarily providers, you know, it's almost kind of like breaking up with your patient. Like how, due to poor therapeutic fit, like how does one go about that? Especially if the patient is like, no, I want you to be my provider.
Yeah. Oh, well, of course you made it very complicated with your last patient statement.
Yeah.
But yeah,
We're trying to cover the whole spectrum here.
gotcha. Yeah, no, and it's good. Yeah, and we should talk about all these. We'll hit on all these reasons that termination may happen. But yeah, you know, so if you're the provider in general, you know, within like 4 sessions is when you should know if it's a good fit, a good therapeutic fit for the relationship. And so there is a period of time, you know, quick in treatment where you sort of know that it's not going to be a good fit. And then sometimes things evolve later on to indicate that. I think if it's a case you've taken and the patient really does not want to terminate and they think it's a good fit for you, this is a great case to bring to one of your old mentors or current supervisors around why you don't want to see this patient. So I think it's rare that you want to terminate someone who wants to stay with you.
Right.
I shouldn't say rare. I should say that's maybe not a great reason to actually terminate a patient. And it's, you know, does it remind you of past trauma you've experienced, right? Like sort of something's going on. If it's you really don't feel like you can help this patient, even though you like them, then it's maybe an easier conversation that like,
right.
Yeah, you know, we've got this good rapport. I'm glad you want to be with me. But in reality, I don't think I'm going to be able to help you as much as another provider. That would be different. Right. So I think if you as the provider want to end the therapeutic relationship, there is more burden on you to find the replacement.
That makes sense.
Because it is definitely unethical. Well, I should watch my absolute terms, but if for me, I could say, or it feels unethical that someone likes coming to you and thinks that you're a good provider, for you to say, you know, it's not going to work because of this, go find someone else.
Right.
I think it would be a situation where, you know, I don't think I'm the right fit with you for X, Y, or Z, and be honest, but I do have this great colleague And if it's okay with you, I'd like to set up an appointment. I think there's a more than doing your average, here's referral list. I think you've got to go one step further and actually find someone to take that patient.
Yeah, and I think that makes sense. It's actually, it's interesting that is both like feels like just the ethical thing to do as the provider in this professional relationship, but it also feels like the appropriate, like, human, nice, kind thing to do for another person who you are kind of quote unquote breaking up with, I guess. Not that you not that like you would break up with a partner and say, but this other person I think would be great for you. But in this case, I think that given the nature of the relationship, makes a lot of sense.
Yeah, no, and I love that you kind of came up with that question and tweaked that question. To have a good discussion about it.
Well, so on the same vein of like termination, and having an ethical approach to termination, non-payment from the patient, I imagine, is also another big reason why termination might be considered appropriate. But then there's also cases of like financial hardship with the patient or family. I guess what are the dynamics at play in that scenario?
Yeah, and I wonder if we should, just to finish up on the other
sure.
kind of, maybe before we go to the financial one, can we jump to the, what if both of you sort of realize this isn't going to be like a good therapeutic relationship?
Okay.
In which case you would, it's pretty quick, right? You'd sort of have that discussion and agree that this would be your last session. And then it would be a more standard, just document in your note, we agreed it wasn't a great fit. I provided the patient with resources, or they're going to, go back and look on their insurance list. And at this time, we consider the case closed. So it's a little bit of a different, it's okay to sort of just give the, resource list and let them find their next care on their own. If there are medications involved, you do want to be respectful and appropriate about that, especially depending on the medication. Sometimes a primary care doctor can take that over, or you want to make sure that the patient has medications to get to their next, to last them to their next provider.
Yeah, I think what I'm picking up is that documentation is always a good thing to be done. Like it not only kind of helps cover you a little bit, but it also, it just provides like a very accurate record of like exactly what happened, so that if you ever need to pull up that information again, then you can. And it's just like it's communication at the end of the day. It's communication and documentation, and just doing the right thing for the betterment of the patient.
Correct. Yeah, and then now on to
everybody's favorite topic of money.
Everyone's favorite topic, that uncomfortable conversation in getting paid for providing medical or therapeutic services. Yeah, money. So probably the number one reason why patients, why a termination happens, or a tricky termination happens, is from non-payment for services. And this can take all shapes and sizes. And we've talked about previously making sure people know what their insurance coverage is, making sure there's a credit card file. And you can do lots of stuff to try to minimize issues around payments. But there is a thriving collections agency industry in the United States, because it is impossible to put 100% safeguards in place. I shouldn't say impossible, because there are some practices that have a model where you pay ahead of time, right. And that tends to, if you have the money in hand, then there's not going to be termination for non-payment of services. But so what do we do when someone can't pay? And Parker, as a knowledgeable but non-mental health practitioner, What do you think is fair or appropriate?
Oh, I was thinking about I believe it's called the accounts receivable report, where I believe that's a report that like a finance person would be looking at, where you kind of determining like what is kind of an acceptable loss of just like we just straight up did not get paid by some of our patients. That being said, it's kind of unrelated to your question, but that's just kind of something that I know exists. Like there is kind of like internally an amount that you would decide is like okay from a business standpoint that you did not receive. That being said, on an individual like account basis, I think it always the smart thing to do is always refer back to whatever your office's financial policy is and whatever boundary you kind of set at the beginning of treatment, because that way you can always kind of cover if you say like it could be you have 30 days to pay us, and then at that point we would have to terminate care if you don't pay, or it could be like if you haven't paid for your last visit and you have another visit coming up, then you should pay. I think it's kind of a business to business case, but I think if it were me, I'd probably go with like, I don't know, you get two appointments, and then at that point, if you're looking for a third appointment you haven't even covered 2 appointments ago, then then it's kind of a trickier conversation, because maybe you're okay with losing the revenue from 1 session, but losing the revenue for 2 sessions is getting a little bit more unsustainable for your business. And then having the conversation about like a third one is kind of like maybe kind of like a 3 strikes you're out kind of type deal.
All right, Dr. Anderson, here's your patient has missed their last 2 sessions, in addition to not telling you their insurance was canceled, so they currently have a pretty large bill, and you just got a voicemail saying, Dr. Anderson, I'm down to my last pill of medicine X, and I'm really scared. What's going to happen? Can you please call in a refill for me? Thank you, Dr. Anderson. Bye. What do you do?
What a question. I feel like I have to think on I just finished watching The Pit, and I feel like I'm kind of going through like some quick medical decision making. I'm not a doctor. I believe the listener has picked up on that at this point, but gosh, I don't know. My gut would be to ask yourself if you're okay with seeing that patient one more time, under the pretense that is like you have to find them something else. You have to find an alternative. Like it's the conversation is happening in the session of like, if we can't receive payment, then here's plan B, where you would go here to receive the care that you need. Or if you already know that in advance, then maybe maybe you already have referral resources for that.
Well, this was a desperate voicemail. You tried to reach back out, as you've been trying to reach out, and they wouldn't pick up or return calls. So you can't reach the patient to have any sort of discussion, but you do know they need a refill of their medicine.
Do you have to see the patient in order to do the refill?
I mean, we'll say not necessarily with this medicine.
Then, I mean, if you have good rapport with the patient, or at least you understand the patient's case and they're a responsible patient and they take their medication responsibly, or at least if you have every reason to believe that they take their medication responsibly, then maybe you would refill it.
We should.
I hope I didn't get my license revoked just now.
We should have. There's so many sort of ethical conversations, and I know I was really throwing stuff at you. But,
that was fun.
Situations like that do happen. Yeah, I mean, I think you're looking back to your office policies is very smart. The term for what you were discussing as a business owner is, quote, bad debt. So in our old budgets, we always have a a portion of the budget that is for bad debt that we know will be non-payment for services. You can also build into your budget, quote, charity care or courtesy write-offs, which is, if you know that you're going to be willing to give away some of your services for free or reduced costs, then you build that into your budget, and then you figure out, what are the terms of that, and what's that going to look like? Is it going to be longstanding patient who lost their job and insurance, and now they're on a covered California plan that you're not with? Does it need to be an existing patient that could go to charity care and then they get a certain discount? But it is important for everyone to think about what will you do, for a longstanding patient who's willing to have that communication and come up with something. Our general approach over all these years is, if we could just have a conversation with someone and get to the point where they could pay anything, we would sort of continue care. So I think it's more someone owes money, they're embarrassed or ashamed, or for whatever reason, they just won't talk to you or return calls or emails. Then you get to a point where it's termination time, because if you can't talk to your patients, almost as you were talking about in this hypothetical medication situation, then it becomes unethical to sort of be refilling medications when you haven't even spoken to patients. And then, when it gets to that point, you do go through a process of documenting phone calls or emails. And then, I don't know now if it's needed anymore, but there used to be sort of a handwritten stamped letter that would go out with or without proof of delivery that, you then put in the chart that we sent this closure letter out on this date. The idea is that maybe someone's phone number changed, maybe email and phone number changed. So send a snail mail letter to a physical address that even if they're not there anymore, hopefully they would get forwarded. And then you've really covered all the bases from a legal standpoint.
And is this kind of where some clinics might decide to have a financial aid policy for maybe some of these kind of financial edge cases to kind of provide an opportunity for the patient to still be seen?
Yeah, exactly. And I think I have found over the years that sort of having set policies around, and to be specific, we're just updating some of our policies. So what we do is, if you are on Medi-Cal, but it's not one of the Medi-Cal insurances we take, but if you show us your card, then you'll get a discount all down to Medicare rates. So, which is lower than what the charge master looks like, but it can still be a significant amount of money. And then if you're not able to do that, there's still a path to write a letter or have a conversation explaining why you can't do that payment, and then having a discussion about what you're willing to pay on a case-by-case basis. So that's, for patients who know they've lost their coverage and want to keep care going. There is that other scenario where maybe someone had a high deductible and then there's a large balance already due. So there's always a policy that we will work out any payment plan for, the previously owed money and come up with a new plan going forward for care. Where that is not always possible, though, for small practices and for people in other situations. So it is a real, try to minimize those events from happening. But for an individual provider, you may not be able to give any pro bono work or sliding scale or reduced fee. That's probably not true. There almost certainly you could do an hour or two a week at a reduced rate, but it is hard to run a business and get that income for yourself. So figuring that out ahead of time, knowing it is going to happen and having a plan about that and having things in your office policies, that is the best you can do.
Well said. I had one more question written down, but I think it's kind of redundant and possibly already answered. So I guess what I want to do is just ask you, before we move on, is there anything else on the general topic that you would like to say?
Yeah, I mean, I think putting a calendar reminder once a month or every other month to plan, run that report of your patient list and read through the patients who are under your care and make sure you've seen them recently. It is a smart thing to do and doesn't take too much time. When deciding to end care with a patient, you've got to document it. You have to put some note in the chart, and until there's something in the chart to indicate that it is no longer an active patient or you've terminated them, they are still active, and that's not good care and not good business or legal practice either. I think that's my...
Well said. And also, shoot, I totally psyched myself out because your statement answered that last question that I had written down. Awesome. Okay, well, yeah, very well said, Tom. Should we move on to the mental health business moment of the week?
Yeah, that sounds good. Yeah, there are lots of things happening. What is last time we talked about office negotiations, and I can share an update that I went to visit several of these offices that I've been slow playing, the negotiations with. And interestingly, one of the offices I went to visit was for another mental health company that was founded by venture capital dollars, and it was now vacant. And
Oh,
I couldn't. I'm like, well, this office is set up pretty nicely for a mental health clinic. And then when I saw on the wall the name of the company, I was like, yes, I've heard about the downfall or issues happening. And well, people who are listening, feel free to Google. The office was in Berkeley, California, so we'll see if there's some detectives out there. I won't go ahead and name the specific company because it doesn't feel super nice, but
yeah.
it was a funny business moment in looking at the office. And I haven't hasn't been shown to the executive director of our nonprofit yet, so we haven't made offers yet, but it's another good strategy after you see the offices to wait some more time before you show your interest. And yeah,
It's interesting, very interesting. Just because I was on a walk with my wife and we're thinking about getting a house, and I feel like some of that advice is, potentially relevant to me as well. Okay, awesome. And we can talk offline about that. But okay, awesome. This has been a good episode. Anything else we should cover before we wrap things up here?
it is very hard to not say anything about exciting AI features
Yes.
coming live soon, but
Yes.
but
We could cover that. We could talk about that in our next episode. It depends. But yes, there are very exciting AI related features coming to the RipsyTech EHR system. Part of me thinks it would be cool to do just an episode dedicated to talking about the system and what we like about it. I don't know. Just throwing that out there. But next episode is going to be our 50th episode of the podcast. This is currently the 49th episode. Yeah, I think we've been doing this for over a year and just haven't even realized it. Just because we've taken certain breaks here and there on certain weeks, but yeah. Anyway, that's exciting. Look forward to the 50th episode.
Yeah, that's
we'll see
cool.
see if we do anything special for it.
Very good. Awesome.
All right. Then I will go ahead and wrap things up here. So thank you for tuning in to this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. As always, if you have any questions or if you're interested in being a guest on the show, send us an email at sitandstay@ripsytech.com. And also, if you're listening on a platform like Apple Podcasts, please consider leaving us a rating or a written review. On Spotify, tap that 5-star rating. And if you're watching on YouTube, feel free to like, comment, or subscribe. These are very small actions that really help us out, and we truly appreciate it. So, any amount that you can do would be great. Thank you. And Tom, I will see you next time.
Thanks, Parker.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.